Yeah, it was about four or 5 years ago. There was a call that came out for somebody that would be interested in chairing the NPDA RCPCH PREM project. So I thought, yeah, there's enough initials for me. I'll have a go at that. And I kind of put an application in, but not really thinking that it would be taken seriously. And Justin doesn't know this, but they interviewed people that applied, and I actually did my interview. It was over the phone. I did it over the phone because I didn't think for a minute I would get the job, so I didn't go for the interview. But I said, well, you can call me on the phone if you want to. And I actually did it with my feet up on the desk. Did you know? I sounded that relaxed. Anyway, I was then completely shocked when I got this email to tell me that they decided to let me become the chair. It's been one of the funnest things, actually, I've ever done. I've enjoyed it immensely. And that was really a result of the committee that I worked with. It was an amazing group of people who turned up regularly for these meetings, who hashed through all of the issues. Kate was on the committee as one of the parent reps. And it was a really great group to work with. So I want to say, first of all, thank you very much indeed to all of those people who were part of this process. It was exciting and it was fun. And we really felt that we were starting to get an opportunity to really listen to the voice of the young people that live with diabetes every day, as well as their parents and their families. So, what was the idea? Well, the idea behind the PREM, the patient-reported experience measure, was twofold. One was to make sure that clinicians understood what their patient's experience was like. And it was also to supplement all of those numbers, all of those bars and graphs and numbers that you saw that Justin presented at the beginning, to try and get a little bit of humanity behind those numbers, to get a feel for what it was like to be coming to clinic. Why does it matter? Why should we do anything about outcomes? Why should we bother? Well, it's a very simple answer. The answer is that your outcomes will improve if you listen to what your patient's experience is, if you monitor your own performance, if you ensure that your care is focused, patient-focused, and most importantly, if you empower your patients. And that doesn't mean saying to them, I'd like you to do what I'd like you to do. Or saying, go ahead and be empowered, and then if they don't do what you want them to do, taking back the power, because they're not doing what you wanted them to do. It's about giving them the responsibility for taking care of their condition, their bodies. Diabetes belongs to them. It's not ours. We are only there to facilitate that care. So, what did we do? Well, we asked parents, we talked to clinicians, and we asked particularly parents though, using focus groups, what is it that makes a difference to a good experience or a bad experience coming to clinic? And everybody on the group went away and interviewed their parents and got all of this data and came back, and we looked at it, we analysed it all, and we came up with these topics. These were the things that mattered to parents and carers. They cared about the waiting time, the time they had to sit and wait in clinic. They cared about who they got to see in clinic and whether they got to see those individuals for long enough. They cared about getting enough information about how to manage their blood glucose, how to manage their sickness, how to manage exercise, how to manage school. And they cared about getting the right information about technology and having choice. That was really important. That came back. So we took all of this information and we put it into the first PREM. And there were lots and lots of discussions about how private it should be, whether it should link to NHS numbers or not, how confidential the information should be. And we also talked a lot about how it was delivered in the clinics and how it was really important for patients to feel that this was being filled out confidentially. Because, you know, if you say to somebody, you know, do you think I'm fabulous, Helen? What can she say other than yes? Really? You don't have much choice, do you? However, if I said to Helen, I tell you what, later on, tell Fiona what you thought of me, you know, then she could be more honest. And that's what we wanted to try and achieve. And we did fairly well. We did get the odd report from the odd patient that they'd been asked to fill out this confidential form and the nurse would just sit next to them while they did it. And then there was the confidential collecting box, which somebody saw the lid being taken off at the end of clinic and having a quick look through all the questionnaires. So there were a few little hiccups, but we worked our way through those. And we managed in 2012, between September and December, September and December, to run the very first patient-reported experience measure across England and Wales. And of the 185 paediatric diabetes units that existed in the country at that point, 170 of them took part, which means 15 didn't, which was interesting. But 170 took part, so we were pretty pleased with that. And then we got the shock of our life, because we got 13,118 questionnaires back. And the poor old RCPCH nearly collapsed under the weight of the questionnaires. All these boxes kept arriving by courier and started filling up one of the rooms in the RCPCH, one of the big rooms in the RCPCH. 170 boxes filled with 13,000 plus questionnaires, and we had no idea how to get the data in quickly. We'd expected a number. You know, we talked about, oh, we'll get something like, 10% back. That's the rate for questionnaires. You'll get about 10% back. We got, if you reckon 25,000 families, we got more than 50% back. So this told us that families wanted to tell us what their experience was. So that was great. But in 2004, the Children Act really emphasized that you have to actively involve children and young people in the commissioning of your services, in the development of your services and in the evaluation. And so we talked about our results and we said, what about the kids? Let's get something for the kids. The poor man's trying to video me. I'm trying not to move around too much. So we decided we'd include children, and we knew that if we did that, that meant that our outcomes, our service would be more relevant, it would increase accessibility, and it would really address the needs of the young people. So, 4 clinics across the UK in, as you can see, the little yellow stars there. So there was Southampton down here, there was London, I can't remember the names, where are they? There was Birmingham, and there was Harrogate. So we had those 4 clinics, and we devised a semi-structured interview, and clinicians from each of those clinics went away and ran focus groups. And they ran them in a number of different ways. So some people did individual semi-structured interviews with groups of kids when they came to clinic. One team took a bunch of kids away on a weekend, an activity weekend, and spent one of the afternoons doing the questions as a shared focus group. So we got all of this data back. And what was really interesting was we asked the kids two kinds of questions. The first one was, this is what your parents think matter. This is what your parents think matter. How important do you think that is? And then we asked them to tell us, what are the things that you like the most about coming to clinic? What are the things that you dislike the most about coming to clinic, and what do you want to be different? If you could be in charge of the clinic, what would you like to be different? So we got a lot of data, as you can imagine, and we used thematic analysis to analyze all of this material. We had 78 young people in the end, so a total of 78 young people. And there were 3 main themes. The first was that they wanted clinics to be about learning new information. That was important. They wanted the communication to be right, and they wanted the clinic structure to be right. But all of it was the superordinate theme was they wanted it to be age appropriate, particularly the adolescents. And here were some quotes about things that young people said. So here's a 10-year-old. She wants it to be fun and interesting. A 13-year-old. He likes to have a good HbA1c. He doesn't want to get told off when it's not good. And different advice from different people. They want to get different views and different opinions. And want to get to know people, That would make their experience a good experience. In terms of the clinic structure, children don't like to wait either. How many people in this room like waiting when you've got an appointment? Anyone? Not one hand's gone up. And yet, we often think that, well, I'm running late, never mind. And I have met patients who've told me they've had to sit and wait for an hour and a half. When I used to take my dad to hospital for his clinic appointments, I remember waiting for 2.5 hours once with him. Nobody likes to wait, and it matters to kids as well. They like seeing the same people. Kids hate seeing a different junior doctor time after time after time. And I'm sorry, junior doctors. I really think it's a shame, because how do you learn otherwise? But when I spoke to one girl, she said to me, the consultants only see the interesting patients. You can see your file on a pile and the consultants come and look through it and pick up the interesting ones. And if you're not interesting, you get given to one of the junior doctors. That was her experience. And she never saw the same consultant once. She just kept seeing a different consultant and had to start the story again and again and again. And you know what? Kids like it to be clean. I mean, that was my biggest shock, having had 2 teenagers. Sorry, Izzy. But, well, they were boys, so that's the difference. But, I was shocked. But kids really like their clinics to be clean. And they like, in terms of communication, to be treated like the expert. They want to be acknowledged. Their expertise in their body and their expertise in their diabetes, they want that acknowledged. So we took all of this information. A comment like "they talk to me and at my level" is something that I like, and we turned it into a statement. And then we did cognitive interviewing. Now, cognitive interviewing is when you take your questionnaire that you've made up and you sit with a group of kids. It doesn't have to be too many, a group of people, whoever it is that you're aiming the questionnaire at. And you read the question to them and say, what do you think that question is asking? And what kind of questions do you think you would come up with if you were asked that? Do you like the way the question is put together? You really get the people that are going to be asked these questions to go through them. So cognitive interviewing is a really important process when you're developing a questionnaire. So you check the understanding, you check the language, and you check the different options. How could people reword it? And we came up with the following. Now, what was really interesting for us is that the things that mattered to parents mattered to kids. Their blood glucose management, help with their blood glucose management matters to them. The time that they wait in clinic matters to them. The advice that they get matters to them. All of those lists of things that we had, that we got from the parents as being important as part of the diabetes clinic experience was important to young people. Apart from one thing, which was being seen on your own. I mean, that was, I guess, my biggest shock, being somebody who's very much an adolescent health person. Actually, only 35% of the young people that we spoke to said that being seen on their own really mattered to them. And it often matters to us more than it matters to them. They like having their mums and dads in the appointments with them. And if they don't want to, it's good to give them the option, but actually they want their parents often to be involved. So I suppose that, and from a clinical experience, I think it's important to avoid parentectomies too soon. Parents are resources. They're part of the solution. They're not the problem. We have to make sure that we're supporting and working with our parents. So we had, let me just quickly put those up. So we had 10 questions in the young people's PREM, and we had this is the ultimate question. There's actually a book called The Ultimate Question. All of the American, big American companies, the hotels that you stay at, the restaurants you go to, the shops that you shop at, Amazon, everywhere that you now have some sort of customer service interaction with, is interested in this question. And it's because all of the research that's been done shows that actually this is the one question that you just need to ask people. Would you recommend us? Have we done enough? However we've done it, have we done enough for us to recommend you to somebody else? So the 2013 and 14 PREM, here we had one for children and young people. We had the same one for the parents as well, and we sent this out again, as you see, in little boxes. We sent it out in boxes, and we asked people. We learnt from our mistakes. We improved our courier service. It all got sent out on time, and unfortunately, this time we got 18,000 paper questionnaires back. We got 9,000 from parents and 9,000 from kids. So we got more back than we got the last time. So the RCPCH really hated us because they really didn't have enough people to put the data in. And actually, we crashed. We crashed the system. That was why we failed miserably to get the reports back to you, because we couldn't get all of this data in. We had this, it was like thousands and thousands and thousands of data points, and we just didn't have enough people to sit and type it in. So, of course, we live in a world of new technologies. So, the following year, we worked very, very hard with some fantastically creative people to develop, finally develop, an online platform and mobile phone responsive system, which means you can do it on your PC or on your phone, basically, on your smartphone. I don't think you can do it on a Nokia, unfortunately, but you can do it on a smartphone and you can do it on a PC. And we created a much more user-friendly version. We used online survey promotional material. Some of you will remember getting your free mug. How excited were you? That was my idea, by the way. Just say thank you later at the break. But we sent all this out to remind people, because here we were in a slightly different situation. How are we going to get people to make sure that people actually did this? And we knew that we would get less. We knew that we would get fewer because people would go home and would forget, but we still gave it a go. How are we doing? And this is what we got. We got 3,000. So we got a third of the paper version that the kids filled out, and we got just under half of the number of parents, so 4,000 parents. But not bad. Not bad for our very first online survey, and we learnt from it, and we will, if we get a chance to repeat this, improve this even more. So, 3 years worth of data now. What were the results? Well, here, if you remember, were the things that mattered to parents. And over the 3 years, all of the things in red consistently, as an average, and it's important to say this was an average, and I think Ragnar's point is very, very well taken, because averages lose information. But all of these things in red scored at, people said they were being seen, they were getting good blood glucose information, good sickness information, carb counting, exercise, school, good information about future health, and that they got to see their doctors, their nurses, their dietitians, and their psychologists where they existed. It was interesting, the psychology category was the only category that had high levels of not applicables, because there are still clinics that don't have psychologists. A lot fewer than before the best practice tariff. I can remember before the best practice tariff came in, a number of NPDAs that came out showed consistently that it was about 20% of clinics in England and Wales had psychologists. It's much higher now. It's much higher now. So those were all, they were things like, in the first one was something around 90%, the second one would be 92%, the third one would be 90% again. So all of these were at ceiling, basically. And the reason that we kept the same questions over the 3 years was we wanted to look at the impact. We wanted to see whether, was this just a one-off for the first time it was collected and then it got worse, or did we continue to see that improvement? And those were all, so those in some ways are questions that we don't need to keep asking because we've done well, we've got to where we want to get to. 90% is a pretty acceptable level, as Justin says, you'll never get to 100%. What about waiting time? So what I've done is I've kind of pulled out the ones that have shown some improvement and the ones that haven't shown improvement, and waiting time really has improved. You can see that there's been a year-on-year increase in people being seen within 15 minutes. There's still these recidivists here who continue to make their patients wait for an hour or more, but it's pretty tiny, it's pretty small. Having said that, I want you to remember that whenever we show a percentage, even if this is something around 2%, roughly 2%. 2% of clinics make patients wait for an hour or more for their appointment. And remember, this is a 10-15 minute appointment. So you've traveled for however long it is, 15 minutes, 20 minutes, an hour to get to your clinic, and then you sit in clinic for over an hour to see somebody for 15 minutes, if you're lucky. Okay, 2% of 25,000 is? Now you all know the answer to this because you're all very clever. It's lots. What is it? What's 2% of 25,000? How many? 500. That's 500 people. They'd be spilling out the doors. So 500 people. So when we use a percentage, don't forget that represents people. So what about emotional well-being? Because that was also something which didn't get the 90% in the same way. What it said was most people kind of strongly agree, about under 40% of people sort of strongly agree that their emotional well-being was looked after, and under 45% said that they felt that they kind of agreed with it. But there's still too many people in the green here. There's still too many people here. Around about 3,000 people are not having their emotional well-being needs met. So it's good, but it's not good enough. And finally, technologies. And what was really nice here was that there is an overall improvement in people's experience of getting good enough information to help them manage the different technologies they come into contact with. So you can see there's a small increase in pumps, people strongly agreeing that they're getting enough information to manage pumps. There's a small information in people feeling that they're getting enough information to manage blood glucose meters, and again, a small increase in CGM. So overall, we're doing really, really well with technologies. It would be nice to switch from agree to strongly agree, but it's a pretty respectable result. What about the kids? So these are the results from the Young People's PREM, which it was only run twice. It was run once in paper and then once online. And the questions in black, and bold, these were all ones where young people rated them over the 2 years, year on year, 95% or more. So doing really, really well across, apart from the 500 people who are trying to get in this room. They're doing really, really well for the 25,000 kids that we are trying to look after as diabetes services. In terms of opportunities to feedback clinic experiences, that has gone down by 5%. As Holly has said, we haven't done the psychometrics, we haven't done the stats. It's a big sample, so 5% might be significant, but we haven't done the stats. But the reports this year were that they didn't feel that they were being given enough opportunity to feedback clinic information. in terms of advice, there was a difference between the parents and the young people, interestingly. So parents were asked on the 24 hours question, did they feel they had good enough access to 24-hour help and advice? And parents pretty much overwhelmingly said yes. I mean, 75% up to 80% over the 3 years. I mean, again, it means that a quarter of that 25,000 don't feel that they do. But if you look, and if you look at the kids, they're saying that they always get it, but sometimes they don't. So there's, you know, it's one of those, it's an area for improvement. It's something that we could be looking at. And in terms of responses to telephone, texts and emails, more parents than kids thought they had adequate responses in time to those, which I was interested in that. I wonder if kids are so much more immediate than older people, that they want a response immediately. You know, they're all texting all the time because people are replying immediately, whereas perhaps parents are calmer. I don't know, Kate, do you think you're calmer than Izzy?
More realistic about how quickly.
Yes, so maybe that's it, that you're, yeah, that there's a sort of different set of expectations about what is good enough response times. And also 9 to 5 contact. The parents thought that 90% of parents thought, again, this is over the 3 years, 90% of parents were happy with their 9 to 5, but only 83% of kids. So last couple of slides, really. Opportunities to meet and talk to other young people. This was a great outcome. This is a really good outcome. In the 2014, you can see the blue bar, how much that's gone up. So you are all somehow creating new and better opportunities for young people to talk to each other. That's happening, and it's happening really well. It's gone from under 50% to over 70%. So that's really, really great. The final question for the final slide really was around the ultimate question. And what I wanted to do is I wanted to bring back in the voice of the young people. So here's a quote from somebody who voted an 8, 9 or 10 in terms of recommending their clinic. And they said, "The team treat us and our child as individuals. They know us well and alter the style and content of their advice to suit our pre-existing level of knowledge and learning style. They make a clinic visit a pleasure. We never get told off if results haven't been great, but instead leave with tools and advice to help us get back on track." I mean, that's great to hear, absolutely great to hear. And there's lots and lots of really positive comments, really fantastically rich narrative comments, talking about wonderful experiences. However, what you can see is, and I've done the math for you, you've got 5,000 kids and parents who are rating their clinics between 1 and 7. So here's an example of somebody who kind of like was around 6 or 7, that in between. I would absolutely recommend this clinic, but they don't have a diabetes psychologist. And as my son is finding his diagnosis hard, I feel every hospital should have one. The diabetes team, however, are fabulous. So that's fine, but what about down here? What kind of experience are people who are saying that they are not going to recommend this clinic to anybody they know? And that's a number. This is what they said. "I waited more than an hour in the waiting room to be seen. They are not deaf aware. There was no interpreter, and I have asked them to book an interpreter, and this is twice I was let down. I am profoundly deaf, and it is very important for me to understand my child's health. They asked me to fax the foods diary my child had. I waited for 4 weeks with no reply. They asked me again to fax because they lost it. I was really let down. I have asked to see a different person, but unfortunately there's only the one. They need to improve the waiting times to be seen and deaf-aware training. thank you, which I thought was very gracious, actually, to say thank you. What about the kids? What did the kids that were giving a 1, 2, 3, or 4 to us say? I'm filling out this survey because the staff here are not organised and have been waiting for at least 30 minutes. They always overbook and no one is ever seen on time. They also treat people like myself, a 15-year-old, as a 5-year-old. That is why I would not recommend this place. And another one, because they don't listen. They think they know what it feels like to actually have diabetes and how hard it actually is to be able to stabilise your blood sugars 24 hours, 7 days a week. And they are never satisfied with your HbA1c test. So where do we go? Well, hopefully we improve the PREM, but we keep asking. And this is a wonderful paper. It's a Harvard Business Review paper, and it's all about the use of narrative outcomes. It's about the use of understanding people's experience through stories rather than numbers. This is something we've started in our psychology service at UCLH now. We run a narrative outcomes measure where we just collect stories and we learn from the stories. So if you're interested in the ideas, I recommend you read this for sure. And I think there's really scope to enhance and improve our ability to hear the stories, because that brings it home to us. You know, that one quote from that one mum who is hearing impaired, suddenly it brings home what it's like to be her and to realise what it is that we're doing and not doing enough of. So I wanted to just finish with that. This is my opinion. This is my feeling that we really need to listen to the people that we work with if we're going to improve and give them the experience that they deserve. Thank you very much.